right, this is the second part of the basic exam practice test number 2. We will continue to the next question. All right, so this is one of the more confusing topics that tends to show up on the basic exam, thermodilution for cardiac output. Marie did a pretty nice presentation the other week and included this topic, so I hope that you have some understanding of this now. But it is a way to monitor cardiac output using a PA catheter. So essentially how it works is a set volume of cold saline is ejected into a proximal port of a PA catheter into the right atrium. And then the tip of this catheter has a little thing called a thermistor, which monitors temperature. So this thermistor will monitor the change of the blood temperature recorded at the PA catheter tip around the time of this injection. A computer then will calculate cardiac output based on the temperature change sensed at the thermistor tip. The measurement is usually done 3 times and averaged in order to calculate cardiac output, because it is dependent on the person performing the test. Questions that often come up about this test are what things tend to underestimate cardiac output and which different variables tend to overestimate cardiac output. So a rule of thumb is anything that causes a temperature change to be slower or over a wider curve, a wider amount of time, will underestimate the cardiac output. Tricuspid regurgitation is a classic example. Concurrent IV fluid administration, so if you're running room temperature or cold IV fluids into the same area, which is the right atrium where the fluid is being injected, there will be a slower temperature change curve and thus underestimate cardiac output. In the same way, either a smaller volume of injectate or a warmer temperature injectate than programmed will have a slower temperature change and underestimate cardiac output. The opposite is true of overestimating cardiac output. So this is anything that causes temperature change to be either faster or have a narrower curve of temperature change. It can also be overestimated in states of extremely low cardiac output. In contrast to the above, a higher volume of injectate or a colder temperature of the injectate will overestimate the cardiac output. All right, this question is about AA gradient calculation. And this really is just a memorization of this equation. So over half of you got this one wrong, and this one's a real freebie. If you just memorize this equation here that you've probably read countless times over, you guys will be given a couple of free points on the question. So AA gradient means the big A means alveolar oxygen, and the little a means arterial oxygen. So alveolar oxygen is calculated. So this is the FiO2 times the atmospheric pressure minus the pressure of water. Now this is always 47, and so this whole value here is 713 because atmospheric pressure at sea level is 760. Then you subtract from this value the pressure of carbon dioxide divided by the respiratory quotient. Now, the respiratory quotient is usually 0.8, but it can change based on diet, which I know I've talked about in lectures past. So with the question, the patient was breathing 30% FiO2 at sea level with a PaCO2 of 50. Now the measured value of the arterial oxygen was 133. So if you put these numbers into this equation, you get 151 minus 133, which is an AA gradient of 18. So please, please, please memorize this equation. You'll get a free point. All right, gas laws. So these gas laws are going to rear their ugly heads. And it's just important that one of those things that sort of on the day before the exam you go through and just memorize which one is which. So the question on the practice test was about Henry's law. which describes that at constant temperature, partial pressure of a gas is proportional to the amount of gas dissolved in the liquid. So in a closed system, the more gas that you have in the atmosphere, the more gas is going to be dissolved in the solution below it. A couple of others to keep in mind. Dalton's law is that the total pressure of gas in a system is the sum of all of the partial pressures. So A, partial pressure of A plus partial pressure of B equals A plus B. Boyle's law, another one that comes up commonly, says that at constant temperature, pressure and volume are inversely related. So P1 times V1 equals P2 times V2. Another way to remember a few more of these gas laws is with a mnemonic. You draw a triangle, and the mnemonic is, can these guys possibly be victorious? And it's sort of a silly mnemonic, but it does work. You write the letters around in a circle on this triangle. And when you look at the triangle, B for Boyle relates pressure and volume. C for Charles relates volume and temperature, with pressure being constant. And Guy-Lussac law relates pressure and temperature with volume being held constant. All right, our next question is about vaporizer characteristics. So there are a few different safety features of vaporizers. There is a design flaw that our question was mainly about. And then there are a few characteristics that all vaporizers that are used today contain. So some safety features. All the knobs turn counterclockwise so that you can blindly reach over and turn the knob the same way. The level of agent in the vaporizer must be displayed, which is the level of gas here, which helps to make sure that we don't run out. We cannot overfill in a normal upright working position, so it's impossible to overfill the vaporizer. And then the machines will allow only one vaporizer to be used at a time. If you try to turn two dials on, it's physically impossible. You cannot do it. The one design flaw of modern vaporizers is if you knock a vaporizer over, there's really no safety mechanism to prevent the anesthetic agent from sloshing around the inside and getting into all of the various chambers. So if this happens, there's really no safety mechanism to prevent too much agent being delivered. You have to put the vaporizer off to the side and let it resettle and find another vaporizer to use. So some characteristics of modern vaporizers, they're all flow over design. This is in contrast to bubble through, so the fresh gas flow flows into a vaporizing chamber where the liquid agent is evaporating into the air above it. The fresh gas picks up the evaporated agent and carries it off. This is in contrast to bubble through, which is like the old copper kettles, where fresh gas was actually bubbled through agent and picked up that way. They're variable bypass. This means that different amounts of gas flow through the vaporizing chamber based on the dial position. So some will flow through the vaporizing chamber and some will flow through the bypass chamber and then meet at the exit of the vaporizer. They're all temperature compensated. That means that at a higher temperature where more agent evaporates, fresh gas flow will change through the vaporizing chamber, and at a lower temperature where less gas evaporates, more gas will flow through the vaporizing chamber to pick up. So a constant amount comes out. And then all modern vaporizers are specific for one agent. So the sevoflurane is only for sevo, the isoflurane vaporizer is only for iso. All right, this question's about flow meter position and cracks. So in our machines that are all automated, this really isn't too important. But in the old machines where there were actually flow meters in series, this became extremely important. And the key to this question is that the oxygen flow meter should be the very last flow meter in order, so that if there are cracks in the other two, or in the oxygen flow meter for that matter, a hypoxic mixture will be avoided. You can see in the top left order, where oxygen is the first one in order, if there's a crack in the air flow meter, the oxygen, some will go out the outlet, but a bunch will escape through the air. If it's second in line and there's a crack in one of them, again, it will also go out where the crack is. So the really only safe ways to do it are to have the oxygen be the very last one in order, so that any cracks in the flow meters behind it are not a problem. Now, if there's a crack in the oxygen flow meter itself, you're sort of out of luck, and that is time to swap out your machine. All right, we had a question on weaning criteria in the ICU. So a popular choice for this was that rapid shallow breathing index is a very important characteristic, which you are correct, but the level of rapid shallow breathing that is acceptable is 105. This is calculated by frequency divided by tidal volume. So basically, if the value is too high, that means that the patient is panting, a fast respiratory rate at low tidal volume, which is no good for extubation. Some other criteria that we tend to look for before extubating patients are a respiratory rate less than 35, a maximal inspiratory pressure of at least negative 20 centimeters of water. So that means that the inspiratory respiratory muscles are good and strong. A PaO2 of at least 60 millimeters of mercury and a PaCO2 of less than 60 millimeters of mercury is important, which means that we're both oxygenating and ventilating. The patient should be at a reasonably low level of PEEP, less than 8 centimeters of water. And also, a patient should have no significant respiratory acidosis, which would cause them the need to hyperventilate, and no signs of increased work of breathing. All right, so in the couple of sessions that I've had with you guys, there have been quite a few questions about microshock versus macroshock. This also was on the practice test and answered incorrectly by many of you. So what microshock is and why that's problematic is it's direct current straight to the heart, and it requires a highway to the heart, either a intracardiac device or a central line, something where electricity can travel through the heart. The difference between microshock and macroshock also is the amount of electricity that goes in. Microshock is dealing with microamps, whereas macroshock is dealing with milliamps. So looking back to microshock, the highest allowable current through the highway to the heart is 10 microamps. If we were to touch a wire with 10 microamps, we wouldn't even be able to feel that there was anything there. Same thing goes with 100 microamps. We wouldn't really be able to tell that anything was there. However, if it's directed directly to the heart via a device, that could cause ventricular fibrillation. That's called microshock. Macroshock is what this guy has experienced in the picture over to the right. It's current that passes through the whole body. 1 milliamp is the threshold for perception. 10 to 12 milliamps is a current that would cause you to let go of whatever was delivering the current. And then 100 to 300 milliamps could cause ventricular fibrillation. So the big key here is to be careful of microamps versus milliamps, which was what I saw on the question on the practice test. All right, so I put this question back on the second practice test because many of you got it wrong on the first practice test, and many of you got it wrong again. So the difference between mean, median, and mode, and the definitions of each. And also how they differ when you have a skewed set of data. So the picture over here on the left shows both a left skewed set of data and a right skewed set of data. This means that a right skewed set of data means that it's normally distributed, other than toward the higher values there are a few more data sets. and the opposite is true on the left skewed data. So the mean, definition of the mean, is the average of a set of data. So if a set of data is skewed to the left, those values over on the left side are going to make the mean lower. So the mean would be lower. If there's a right skewed set of data, it means that those lagging data sets will cause the mean to be a little bit higher. So the mean will be the rightmost value. The median is the middle number of a set of data. This will be the middle number in a normally distributed set of data, regardless of whether it's skewed or not. The mode is the most common value. If you listed each data point out, the mode is the number that most commonly occurs. And in a left skewed set of data, it will always be at the highest part. So in a left skewed set of data, it will be highest. In a right skewed set of data, it will be lowest. And if you just sort of if you get a question like this and you just sort of draw these out, you can sort of rationalize how mean, median, and mode will set themselves up. All right, our next topic is on the ASA classification system. So I put the question that was on the practice test over on the left. So they wanted to know which the appropriate ASA classification is for a patient who is in the ICU, is intubated and on vasopressors, and has evidence of acute kidney injury due to urosepsis. The patient comes to the operating room for a cystoscopy with stent exchange, and they wanted you to pick the correct ASA classification system. So we can see over on the chart, ASA1 are completely healthy patients with no medical problems. ASA2 is mild to moderate systemic disease that is reasonably well controlled. Sometimes the difference between 2 and 3 can be a little bit difficult and somewhat subjective. ASA3 would be when the disease tips over into the severe category that limits activity to some extent. ASA4 is defined as a severe incapacitating disease that's a constant threat to life. Many of you chose ASA5, which would be a moribund patient who is not expected to survive for at least 1 day without surgical intervention. I believe that this is really an ASA4 here by description, because there's no evidence that the patient will necessarily die without this procedure, but they do have severe processes occurring, this urosepsis, which is causing them to be needing vasopressors and ventilation support. And so therefore it's a constant threat to life, but there's not necessarily evidence that the patient will die without this procedure. A true ASA5 would be some patient that came in and was on the cusp of death without dramatic action. All right, this question was about the test dose after epidural catheter placement. Test doses are meant to do really 2 things. It's meant to eliminate the possibility of intrathecal placement, and it's meant to eliminate the possibility of intravascular placement. So I'm not sure how many of you have worked with Ken Truesdale on OB, but every time he gives a test dose, he aspirates and chants, "No blood, no CSF, no blood, no CSF, no blood, no CSF," and the nurses kind of chuckle, but really that's important, because that's exactly what we're trying to avoid. We want to make sure that it's not in the intrathecal space. We want to make sure that it's not in a blood vessel. So criteria. So test doses are combined with lidocaine. It's usually 1.5% lidocaine with 1 to 200,000 epinephrine. So if the catheter is in the blood vessel, you'll see an increase of heart rate due to the epinephrine, and a positive test dose is considered greater than 20 beats per minute increase over baseline. Also, your blood pressure will increase due to the same reason, at least systolic blood pressure of at least 15 millimeters of mercury or greater. And then if the catheter is intrathecal, the 1.5% lidocaine will give some semblance of a spinal block. So that would be extreme lower extremity weakness, or in this question, the inability to dorsiflex the ankle. Now I put this picture here over to the right just to add another topic that sometimes comes up on the basic exam. So when we put in an epidural catheter for labor, we are looking to block the T10 through L1 segments, which are the segments that provide sensory innervation for stage 1 of labor. And then the sacral nerve roots are for stage 2 of labor, S2 through S4. That can come up sometimes as well. All right, we had a question about appropriate tourniquet pressure. So this is a picture of a tourniquet, much like we have in OR number 11 with the ortho folks. The problem with tourniquets is that pressure must be high enough to occlude the arterial flow of the limb, but not so high that it causes nerve injury. So wider cuffs tend to be better than narrow cuffs. It spans the pressure out over a larger area of tissue. And the systolic pressure that the tourniquets are inflated to should be above the systolic pressure, but not infinitely high, or it will cause nerve injury. So I believe this is data from the AORN, the OR Nursing Association. But for systolic blood pressures in the normal range, less than 130, it should be greater than 40 millimeters of mercury above systolic. For higher systolic pressures, it should be at least 60 millimeters of mercury above systolic pressures. And for extremely high systolic pressures, it should be 80 millimeters of mercury above the systolic pressure. All right, this is a topic that comes up over and over again, and I know that I've given you all several questions on this. So core body temperature, temperature measurements, and the different ways that heat is lost during anesthesia. So there are 4 reliable locations that are where core body temperature can be measured. They are and they're each associated with their own central blood supply. So they're a tympanic membrane. This is close to the circle of Willis. The PA, this is the gold standard because PA catheter sits directly in the most major blood vessel in the chest. The esophagus, which is closely associated with the aortic arch, and the nasopharynx, which is closely associated with the internal carotid artery. There are other places that estimate core body temperature well, but not quite as well as the 4 most reliable sources of temperature measurement. Their bladder, this is just an estimate because it does require high urine output. The rectum, this is a good place, but can sometimes be altered by the presence or absence of fecal matter. The axilla sometimes is a good estimate, although skin tends to be a bit unreliable. Skin and oral cavity. Over here on the image to the right shows the 4 different ways that heat is transferred. Those are radiation, convection, conduction, and evaporation. The most common, or the way that most heat is lost, is through convection, which means through circulating air currents, which is why the bear hugger is the best way to heat or warm a patient. All right, we had a question on gastric emptying. So for clears, which is a little bit shocking for most of you, for clears, the half time for emptying is really only about 12 minutes. This means that 90% of the stomach is emptied of clears after 4 half times, which doing quick math would mean 48 minutes. So you may ask, why is the NPO time for clears 2 hours? This is so that all patients are included, even people with slowed gastric emptying time. So people with diabetes, people who use chronic opioids, people in renal failure, and stress can slow gastric emptying as well, which really would encompass most of our patients. So that is why the recommendation is 2 hours NPO time for clears, but the half time really for a healthy person is really only about 12 minutes. This image just reminds us about how gastroparesis tends to develop in diabetics through damaged vagus nerve inputs. All right, there's a question on post-operative pain control and different agents that are used and which agents are not so great. So there are many different agents that can be used post-operatively. And there were several sort of off-the-wall options for this question. So IV buprenorphine is not a great agent for pain, but still somewhat effective. IV sufentanil can be used, of course. It's a very potent opioid. Our patients tend to go home with oral oxycodone, which is an effective pain medicine. And even IM meperidine can have some mu activity, not a great choice, but does have some mu activity. The correct answer for which was the worst would be transdermal fentanyl. And the reason for that is that transdermal patches really take a very long time to have any sort of action. Transdermal patches usually take about 16 hours from time of placement until there's some effect noted. And so in the post-operative period, that is not a great method for pain control. The patient would sit in pain for far too long. All right, our next question was about intrathecal opioid and appropriate dosing of such after outpatient surgery. So it gave you two options, morphine and fentanyl, and then two different doses for each of those. So in an outpatient setting, morphine is contraindicated. The reason for this is that morphine is a hydrophilic opioid. It camps out in the CSF for a prolonged period of time, and therefore long-term respiratory monitoring is needed. Long-term meaning for at least 24 hours. There's a biphasic pattern of respiratory depression, meaning that about several hours after injection, there's a period of significant respiratory depression, and then again, near 24 hours, for right around 20 hours, there's another period of respiratory depression. Normal dosing of intrathecal morphine is somewhere between 100 to 200 micrograms, as noted in this table. Fentanyl would be a more appropriate choice for outpatient surgery. It's a lipid-soluble drug, which means that it has a shorter duration of action, more systemic absorption, and a reasonable dose for fentanyl intrathecal is somewhere between 15 to 30 micrograms, or 25 to 75 if you're looking at this table. All right, we had a question about the pathophysiology of atelectasis. Hypoxemia tends to occur due to a hypoxemia can occur for many reasons, but one of the reasons is due to a right to left shunt, which describes atelectasis. So this is perfusion without ventilation. It means that blood moves from the right side of the heart through to the left side of the heart without picking up any oxygen. Hypoxemia with a right to left shunt will not necessarily be overcome by increasing oxygen concentration, because blood never touches the oxygen. So, it doesn't really matter whether the patient's breathing 100% oxygen or 20% oxygen. Because it doesn't pick up, because the blood never touches the oxygen, the oxygen concentration really doesn't matter. This picture over on the right here, the circle is around the idea of shunt and how poorly oxygenated blood bypasses the lung without picking up any oxygen. Other causes of hypoxemia post-op, you do have to rule out always when you go to the PACU. They are hypoventilation, medications, either residual neuromuscular blockade or opioids, diffusion impairment, meaning different lung diseases, and VQ mismatch, which is another way to describe dead space ventilation, which we talked about earlier. There is a question on a few definitions that arise in cases of malpractice. So The question asks you to differentiate assault and battery. So assault is putting a patient in a potentially harmful situation, but physical contact is not necessarily required for assault to have occurred. Battery is the actual touching of a patient without consent. And this comes about in anesthesia and surgery when a wrong-sided block or wrong-sided surgery occurs, because the patient has consented to the procedure on the correct side. So when we touch the patient in a medical way on the wrong side, that in effect is battery, because they did not consent to that touch on that side. Medical negligence is a breach of duty that ultimately causes harm. Contrast that to criminal negligence, which is when a breach of duty occurs because the care was far, far from the standard of practice. And the way I like to think about that is the Dr. Death podcast. That crossed the line into criminal negligence just because of how far he was practicing away from the standard of practice. Abandonment is another term that comes up. That's when continuity of care becomes interrupted once patient care has been assumed. In anesthesia, it would be when we took over a case and leaving that case without necessarily handing off to a colleague. All right, this question went over the definitions of sensitivity, specificity, and both positive and negative predictive value. So sensitivity is the true positive rate. It means the proportion of individuals who are correctly identified as having a disease. And specificity is the opposite. It's the true negative rate. It identifies the proportion of individuals who are correctly identified as not having the disease. Contrast these two to positive and negative predictive value. So a positive predictive value means the rate of a positive test that actually has the disease, and the negative predictive value is the rate of a negative test actually not having the disease. So sort of sort these out in your mind however you can, and sometimes these do come up on the tests. Okay, our last question talks about GFR and the pressures in the afferent and efferent arterioles. With an increase in pressure in the afferent arteriole, this is the arteriole leading into the glomerulus, higher pressures will increase GFR. And this really is a question about plumbing. So higher pressure in this side will force more flow into the glomerulus. By contrast, an increase in the efferent arteriole pressure will decrease GFR. So the higher the pressure on in the arteriole leading away, the less blood is going to be forced down into the glomerulus and filtered through the capsule. So high pressure leading in will increase GFR, high pressure leading away will decrease GFR. All right, that's the end of the presentation. Thank you a bunch for watching. If you have any questions at all, please reach out, talk to your friends, colleagues, other attendings, or talk to me. You're all going to do great. You've been working really hard, and can't wait to see the good results. Take care.